Katherine, and I'm head of school here, and I'm delighted to introduce you to the fourth installment of the Falmouth Academy Community Series. And this evening, we are thrilled to be partnering with some terrific organizations, and I want to just first thank the community for supporting the Media Community Series, and it is sponsored in part by the Woods Hole Foundation. I'm going to step out of the way for a moment and introduce you to Dr. Larry Alade, who is with NOAA Fisheries and is the co-chair of the Black History Month Planning Committee. Larry.
Good evening, good evening. Thank you all for being here in person, and if you're streaming online too, we welcome you for joining us at our final installment of Black History Month. It's been a challenge, as you know, trying to get this event going, but we really truly appreciate everyone's support, being a part of the program, and continue to engage in these very important topics. And so we have a very special guest for you today, and a very special topic that we're going to talk about with regards to health and wellness. But before we jump in, I want to certainly invite Rob Feeler to give some remarks on behalf of the Diversity Advisory Committee in Woods Hole. Welcome, Rob.
Thanks, Larry. Good evening. My name is Rob Feeler. I'm the Center Director of the U.S. Geological Survey Coastal Marine Science Center here in Woods Hole, and the chair of the Woods Hole Diversity Initiative. Welcome to the Woods Hole Scientific Community's ongoing 41st anniversary celebration of Black History Month. For those of you able to attend or view the recordings of the previous virtual events this month, you have partaken of a truly engaging and rich series that delved into the achievements, the challenges, and the inequities in Black health and wellness. This evening's presentation by Dr. Kathryn brings these themes into the context of the ongoing COVID-19 pandemic, which has drastically and disproportionately impacted communities of color. In 2004, the leaders of the 6 Woods Hole Science institutions, the Marine Biological Laboratory, Northeast Fisheries Science Center of NOAA, Sea Education Association, the USGS, the Woods Hole Oceanographic Institution, and the Woodwell Climate Research Center signed a memorandum committing our institutions to work together to attract and retain a more diverse workforce. That memorandum established the Woods Hole Scientific Community's Diversity Initiative, which in turn established our Diversity Advisory Committee to support the institutions in their efforts to promote diversity and inclusion in and among the Diversity Initiative institutions, as well as the wider Woods Hole, Falmouth, Cape Cod, and Islands communities. On behalf of the Diversity Initiative, I'd like to thank the Falmouth Academy for hosting this evening's event, Falmouth Community Television for streaming live tonight's and several of this month's programs, and the Woods Hole Diversity Advisory Committee, especially the Black History Month Committee, and the co-chairs Angie Scott Price and Larry Alade for putting together another outstanding series of events. Thank you again for attending tonight, and I'm pleased to turn things back over to Larry.
Thank yous, because none of this could not happen without the collaboration of Falmouth Academy. I would like to say a special thank you to Carol Pablo and Amy Galvan, who have been very instrumental in collaborating with us to make tonight really happen. So a little bit of a brief remark about Black History Month, the Woods Hole Black History Month Planning Committee. Every year, members of the Woods Hole come together to celebrate Black History Month, to build a stronger community through diversity, and our committee serves the 6 research institutions that was mentioned earlier in the village of Woods Hole. And we've been the hub of marine sciences and in STEM areas since the 1870s. And the purpose of our work here is to work towards creating an environment that is quite inclusive and welcoming for all people from various backgrounds. And that's under the part of the governance of our diversity and inclusion plan as outlined by Rob Feeler. So a little bit about this year's theme. Take our national theme from the Association of the Study of African American Life and History. And this year's Black History Month theme focuses on the importance of Black health and wellness. The theme highlights not only the legacy of Black scholars and medical practitioners in Western medicine, but also considers other forms of non-traditional forms of wellness that's been done so well in the Black communities. The theme also highlights some of the historical and contemporary disparities in healthcare access in marginalized communities. In the 21st century, our understanding of Black health and wellness is broader and more nuanced than ever. The growing normalization of mental health as a form of wellness continues to increase the effort of destigmatizing mental health. We see Black girls doing the breath work, and there are whole yoga studios dedicated to people of color. But we recognize that there's still more work to be done to make progress. And so with that said, I will turn the program over to Matt, who's going to introduce our special guest today. Thank you very much.
So Dr. Katherine Hall is the Deputy Executive Director for Population Health and Health Equity at the Boston Public Health Commission. After receiving her PhD in microbiology and molecular genetics from Harvard University, she spent 10 years in the biotech industry tackling problems in drug discovery and development, where she became an Associate Director of Drug Development. Dr. Hall returned to Harvard Medical School in 2010, joining the Fellowship in Integrative Medicine at Beth Israel Deaconess Medical Center in 2012, and receiving a Master's in Public Health from Harvard T.H. Chan School of Public Health in 2014. Dr. Hall is also an assistant professor part-time in the Division of Preventative Medicine at Brigham and Women's Hospital and Harvard Medical School, and serves as the interim director of basic and translational research at Usher Center for Integrative Medicine at Brigham and Women's Hospital and Harvard Medical School. In her spare time, she also earned a master's in documentary film from Emerson College. Please welcome Dr. Katherine Hall.
It's such a pleasure to be down here in Falmouth, to the warm-ish serenity of these wonderful, welcoming school, and also the beautiful seashore. It's really nice to be here. I think I'm very socially distant from everybody, so I'm going to take off my mask. I did test before I came and tested negative for COVID-19. So it's a pleasure to be here, and I'm going to be talking about COVID-19 and health inequities, two pandemics or epidemics that have really, I think, affected many of us, all of us, and some of us more than others. I'm going to touch on a third pandemic, and that is the infodemic, as called by WHO. And I spent years as a placebo researcher. I still do placebo research part-time at Harvard Medical School. And I'm actually going to weave in how placebos and nocebos are actually affecting what we're seeing now with these two pandemics. So when I sat down to work on this talk, I wanted to take some time to go back over COVID in the last more than 2 years. And as I looked through the internet for interesting slides that might tell the story of COVID, and we all know this story, we've all watched it on the news and experienced it firsthand. There's so much about 2020, but it's like 2021 didn't exist. You can't find a timeline of 2021, which I think is so profound. This is 2020, and many of us remember that there was a mysterious new illness early in January, and then we started to learn that it was spreading and that the world was shutting down, and we all listened as Dr. Fauci explained to us that we needed to flatten the curve, and certainly there was an uptick in mental issues for many people, mental health issues. And then, just as we were having new hope, there were new mutations, and there was the Delta variant and the surge at the end of that year, only to then greet 2021 with finally vaccines, and that was, I know, very exciting. And many of us lined up to get those vaccines, but not all of us lined up to get those vaccines, and I'm going to talk a little bit about that tonight. This is a very detailed slide, and I just want to look back and see what that looks like, because I started to do this. You ever make one of those slides where you think, oh, this is a good idea, and like you know, half an hour into it, you're like, what am I doing? Why am I doing this? But you can't stop because you're like, oh my God, I remember that. I remember that. I remember that. And this is how 2021 was for many of us. You know, whether it was, you know, Omicron coming up towards the end of the year and kind of blowing away all our hope that we kind of gained over summer, or the boosters that we learned about, or, you know, J&J being put on hold. I mean, it's such a story that is so much a part of the fabric now of all our lives. And I want to tell you how we experienced it from the perspective of the Commission, where our job is to really keep track of the epidemic and understand how it's affecting the people in our population, which specifically is Boston residents. But Boston residents don't live in a vacuum. We live, you know, next to Brookline, next to Cambridge, and hundreds of thousands of people fly into Logan Airport every day. So we are part of this complex network of people. And so our job at the Boston Public Health Commission, one of our jobs, because we have many, many jobs, is to really track the virus and the spread of the virus to the community. And we came up with our metrics to keep track of them. We kept track of the case rate per 100,000, and we kept track of the percent positivity. That's the number of positive tests out of all the tests done. And all these metrics have their own limitations, right? Because not everybody is getting tested. So if you're looking at percent positivity, you're missing the story of the people who are not getting tested. And sometimes you miss cases. And so we had to do the best we could to understand what the virus was doing in our communities. In this graph, I love this graph because it really tells a story starting in 2021 all the way through 2022 of the first wave around April, May of 2020, the second wave around January of 2021, and the little blips that we had leading up to this, I guess, tsunami that was Omicron at the end of last year, beginning of this year. Throughout this, we, like many people did, watched the water. And I'm a bench scientist. I started off doing molecular genetics, and I worked a lot with RNA. And if anybody here has worked with RNA, you know it's one of the most sensitive things that you can, if you just touch it, it disappears. Because you have enzymes on your fingers that break RNA down. So it's kind of amazing that we can measure how much viral RNA is in the wastewater, right? And tell what is happening in our communities. And what's amazing is this curve that you're looking at here, that again goes over time and tracks, that tells the same story. You see the little mini waves and then the tsunami of Omicron. That water is over 90% correlated with what we were seeing with positivity and case rates. So we started to rely on the water and also the case rates and test positivity to get a sense of what was happening in the community. And as we did this, we also paid attention to the hospitalizations. And again, that big early tsunami of hospitalizations was Delta. And we like to think that what kind of made the peaks that happened later on was not as dramatic. We'd like to think it was some of the interventions that the public health community and the scientific community were able to bring in. Vaccines, masking, social distancing, testing so people knew that they could quarantine or isolate. And so the story about hospitalizations is critical, and the CDC just recently, on Friday, actually came out with a whole new set of metrics that are really interesting, that they're asking us to use to measure how the pandemic is impacting people in our counties and in our states. One of the metrics that they're looking at is the number of ICU beds that are being used. But you can see this graph is kind of all over the place. But if you take all this data and you kind of put it together here, it tells a really great story. And it tells you the story that the blue, for those people, I was telling somebody about this at a meeting on Friday, and he pointed out to me that it was colorblind and he couldn't see what I was talking about. So I'm going to describe what we're seeing here in case anybody is colorblind. So the blue wave is the first wave that crests and that's the water supply. The water supply goes up first, and then it's followed by the green wave, which is the second set of waves that is a little bit delayed, and that is the positivity and the case rates. And those two curves are almost 90% or over 90% correlated. And then after that, almost a week after that, or a couple of weeks after that, in some cases, comes the hospitalizations. And then you see those ICU beds are just kind of all over the place. So working together with our epidemiologists and our biostatisticians, we've been keeping track of what's happening in our communities so that we can recommend to the mayor things like masking or our Be Together mandate, where we had people have vaccine cards to go into settings that were indoors, restaurants, gyms. And these metrics, I think, have been very helpful, but they really are not telling the full story of COVID. And that's what we're here to talk about today, is what was underlying these aggregate metrics. And when you look by town in Boston, you see a very different story, right? You see that in red, orange, I'm not sure what it's showing up as, are the towns where the rates are higher than the average, and in green are the towns where the rates are lower, of cases on the left and deaths on the right. So when you take a look at one layer down, what you see are striking disparities in the cases and the rates by neighborhood in Boston. And Boston is just one city, a large city, or a densely populated city, I should say, in the United States, but across the country, we see these differences by towns and cities. So why were people in some neighborhoods at greater risk for COVID-19 infection and death? Well, one of the things we learned very quickly was underlying conditions and age, right? So the older you were, the more susceptible you were to having a more severe course with COVID. But underlying conditions such as cardiovascular disease, diabetes, or chronic lung disease would also influence negatively the course of the disease. So people with these underlying conditions had were more likely to get hospitalized, more likely to be in intensive care. Another reason was because risk of serious illness with coronavirus was also associated with people who had low household incomes. And this is a graph that really shows that the lower your income, the more likely you were to have serious illness with COVID-19. And here's another graph. This one shows, and it might be hard to see, maybe it's not so hard on that scale, but frontline and healthcare workers that were public-facing, workers that had to take public transportation or were running public transportation, were at higher risk for COVID-19 infection. So we started to see a pattern here that it's not just about certain towns randomly, it's about people with certain types of exposures. And when we thought about it and when you looked at it, it became very quickly apparent that not just underlying health conditions or low household income or public-facing positions, but people who lived in aggregate settings, congregate settings, who had multi-generational housing, who lived in low-income neighborhoods, who had limited access to care and testing, and who tended to have, despite all of this, hesitancy to get vaccinated once vaccinations were available. So what is happening? What is the cause of all that? Well, what we're looking at are the social determinants of health. And the social determinants of health are conditions in which people are born, grow, live, work, and age. Sometimes they call them SDOH, or social determinants of health, are shaped by the distribution of money, power, and resources throughout local communities, nations, and the world. And differences in these conditions lead to health inequities or the unfair and avoidable differences in health status seen within and between countries. So, social determinants of health are from this wonderful image from the CDC can also relate to education and limited access to good education and quality education, limited access to health care and quality health care, the neighborhood and the built environment, social and community contexts, and economic stability. And I want to just do a deep dive into economic stability because there's so many of these factors that influence health that I think to really get a sense of what they are, let's take a close look at one. Let's take a close look at redlining. Redlining codified patterns of racial segregation, and there is not a major town in this country that did not have redlining. So with redlining, lines were literally drawn, and neighborhoods were characterized as given a letter, D, C, and based on the letter that you were given, people living in that neighborhood got more or less access to mortgages, to loans, to financial investments that would allow them to build their neighborhoods and improve the quality of the schools in their neighborhoods and to include the quality and access to healthcare in their neighborhoods. And even though this is happening back in the 1930s, there's a really wonderful study where they looked at neighborhoods that had redlining and neighborhoods that didn't have redlining with similar racial groups of people, and you really see that this act of redlining caused segregation and caused these social determinants of health to have very negative impacts on the people that lived in these neighborhoods even today. Availability of credit had significant impacts on every dimension of neighborhood life in terms of the quality of the real estate, the willingness of investors to come in, property prices, and the emergence of predatory practices. Slumlords moved in, squeezing value from subdivided rental homes that otherwise might have been owned by families, and commercial investors stayed away. And blacks, African Americans, were especially discriminated against with this housing practice. And they weren't able to go elsewhere because they couldn't afford to go elsewhere, and so they lived in these neighborhoods, and they have borne the consequences to this day of this very aggressive practice in racial segregation. And this is one of the key structural racism elements that drives health inequities, drives these disparities, and drives what we're seeing today in COVID. So I want to take a look at what was happening in our neighborhoods across Boston by race. When we look at the rates of cases by race or ethnicity, we see a very telling tale. We see that Black and Latinx residents of Boston had the highest case rates. On the left and on the right, you're looking at the death rates of Black people in Boston were almost, and this is cumulative since the beginning of the epidemic or the pandemic, were almost double that of whites and Asians and Latinx residents. This is the price that people in our state have paid for this aggressive form of racial segregation. So, structural inequity, what is that? The systemic disadvantage of one social group versus others by race, ethnicity, gender, or gender identity, class, sexual orientation, through unequal allocation of power and resources, which manifests in disproportionate social, economic, and environmental conditions. Structural racism, the totality of ways, historical and contemporary, that have reinforced a system of hierarchy, privilege and power that excludes non-whites. You know, I was doing some reading on health inequities and health disparities recently, and I came across an article that really, I think it was really painful to read. And it was about a summit that was held in Germany around the time before the Nazis came to full power. And what they did was they wanted to figure out how they could marginalize people of Jewish ancestry in Germany. And they came to the United States, and they were so impressed with how the United States had marginalized and oppressed African Americans that when they came back, that was their playbook. And they said that what was amazing about America was that they did this with impunity because they were the land of the free. And that really struck me because I don't think we realize how insidious structural racism is and how sick, literally, physically sick, racism makes us. These long-standing systemic health, social, and economic inequities have put some members of racial and ethnic minority groups, as well as people with lower incomes, at increased risks of getting COVID-19 or experiencing severe illness regardless of age. That's the thing, that graph that I just showed you that showed the difference by race, it didn't account for age. So if we were to account for age, what we would see was even more young people of color were dying, and the people who were white were dying more often because of old age. So what that tells us is that there is even greater disparities by age across these racial ethnic groups. In public health emergencies, these conditions can also isolate people from the resources they need to prepare for and respond to outbreaks. So structural factors, like I said, include access to clean water and sanitation, overcrowding, low-wage employment, racial profiling. Things like hand washing, physical distancing, and wearing masks make for differential exposures. So some people can, when they get a positive test, they can go home and stay home by themselves or stay home in that part of the house. And it was interesting because one of the things that we did at the commission and the Health and Human Services at the city, Boston City did, was we had a weekly meeting with the community. And I remember, saying just kind of going through the things to do when you get a positive test, just go home and isolate. And people said to me, Dr. Hall, we can't isolate. There's no room for us to go in. You need to tell us things that we can do so that we can live in very close quarters with people who we don't want to get infected. And so I think it really underscored to me that we need to really think about everybody and how everybody can stay safe and really think about COVID, not just in generalities, in those nice graphs that I showed you, but the people in the neighborhoods, in the congregate homes, living with grandmothers and grandfathers and grandchildren who are more, out running around, bringing COVID back to people who will be more susceptible. So again, the other side of this is healthcare access. Not everybody wanted to go into the city. And when I say it's ironic, because going into the city means like going into the Brigham or Mass General from Alston, Brighton, or Roxbury, or Dorchester, right? But not everybody wants to go in and see the physician. What we learned was there was a lot of fear, a lot of mistrust, and I'm going to touch on that in a moment. But all these factors affected people's health and caused these disproportionate rates of infection and death. And so one of the things we realize is that we need to get people vaccinated. We need to meet them where they are and help them get vaccinated. And at the point I joined the commission in October, through to now, we saw again, not just disproportionate levels of COVID-related cases and deaths, but disproportionate levels of vaccination, disproportionate vaccination rates. And what did that mean? That meant that many people in the very neighborhoods that had the high rates of COVID didn't want to go get vaccinated. They had mistrust of the government. Mistrust of the government, mistrust of the medical establishment. And you might think, oh, well, you know, just show them the data, right? And it's not that simple, and we're going to get to that in a minute when I tell you about how placebos and nocebos come into this. So what we did at the Commission, we took our services to the community. We proactively reached out in community meetings. We let the community lead us. We talked to faith-based leaders, and we set up testing and vaccination clinics all across the city, and in particular in neighborhoods where we saw this disproportionately high rates of COVID and low rates of vaccination. And I'm really proud of some of these clinics that we did. At the Commission, I have to say, like when you get a text at 3 o'clock in the morning, that's when our workday began. And when it ended at 5, it was time to read all the emails that came in from the day. And when I finished that around 10 o'clock, it was time to actually do some work. And we had an amazing team, many of us all in this together, still working. But our teams were out working with EMS, the Emerging Medical Services, which is part of the Commission, to stand these clinics up. And these men and women are amazing and stopped at nothing to really get people vaccinated and get them the tests that they needed. So I'm really proud of that, and I think we're getting a little bit of a break right now, but hopefully it will last for a while, we'll see. But let's come back to medical mistrust, because we were out there, right? We would get all these people together, we would stand at the clinic, we'd put the signs up, we made the PSAs, we did the social media, the Facebook, we went to the community settings. It's like you're going to have, you know, all these people come, and then a lot of people came, but the people who first came were the people who came for boosters. So there were people who already had kind of understood the importance of vaccines. How are we going to reach people for which medical mistrust was the thing that was standing in the way? How do you tell somebody that, no, it's safe? And I just want to take a minute to talk about the brain. So as I said, I'm a placebo researcher. And what's amazing about the placebo effect is it's this power of a sugar pill or a sham surgery or a saline injection to cure your sciatica, to cure your migraine, not cure, I should say, to alleviate your sciatica, alleviate your depression, alleviate your pain. Why? Because the way our brains work is we have this thing called the prefrontal cortex, in particular the ventrolateral prefrontal cortex, and these various areas that are making meaning of our life, making a model that allows us to project onto what's coming in. Because if I had to pay attention and, you know, like to every single seat in here and every person in here and what everybody is doing, I would go crazy, right? Because it would be just too much information. So what does my brain do? My brain built a model of where people are sitting, and I'm not expecting anyone to just jump up and scream, right? If they jumped up and screamed, that would be outside my model, and I have to update my model. Similarly, I can build my expectations by conditioning, right? Pavlov's dog. He, you know, paired some yummy meat with a bell, or people say it wasn't a bell, but a stimulus, and then enough times that without the meat, just with the bell, the dogs would salivate. So the dogs built a model, basically, of what the bell meant and had a biological reaction to it. Similarly with placebos, we build a model of what this pill will do for me, and my body does the rest. Well, that works really well when it's positive. Unfortunately, it also works when it's negative. So if I go into clinical trial, and this has been proven in many studies for statins, where it's known that statins can cause muscular pain, the people in the placebo arm have the very side effects that the people with statins are expected to have. Why? Why would a placebo give you muscle pain? And basically, because people know or believe that they're going to get muscle pain, they are resistant to taking a statin. Similarly, because people have been told that vaccines are going to harm them in some way, when they do get the vaccine, they have terrible pain. And I'm not minimizing anybody's pain. Any pain is real pain. The critical thing is that it's the information that we get that can guide the response. And that's why our words are so important. And as we thought through how to reach people through this pandemic, we had to really think not just about translating our flyers to Haitian Creole or to Brazilian Portuguese. We had to think about how to convey a positive message to a person from a different culture in a way that didn't make them more suspicious and have more mistrust. We haven't solved it, so and that's why we work really closely with the community to help us figure this out, because we need to reach people. We need to understand their beliefs, their norms of their behavior. We had many focus groups, and we're continuing to have focus groups. We have physicians embedded at Boston Public Schools so that they can be on the ground to understand what the dynamic is going on, because we're really worried about our children. We want to protect our children. I understand that the students here are 98% vaccinated. That's a record. I've never heard this. This is amazing. Congratulations. We make videos. And it's really interesting because, I come from a very academic setting where, you do an experiment, you publish it, hopefully in a really good journal, and you write it up in English and you're done, right? After you've gotten reviewed and you've done your revisions. But as soon as we would produce a product, the first thing our community partners would say is, can I get that in Arabic? Can I get that in Mandarin? Can I get that in Cantonese? And so we had to, the commission has always done this, but when you're kind of fighting a pandemic, you're not always remembering all the things you know to do, and we had to be reminded to do it, and we had to engage with people, not just about our pamphlets, but our videos. Social media is, as we know, the source of a lot of misinformation. In fact, WHO coined the term an infodemic. I probably should have said there are 3 pandemics: COVID, health disparities, and the infodemic. It is amazing how much, I don't need to tell anybody here. If you Google statin resistance, you get over 1 million hits. Why are there over 1 million hits about statin resistance and side effects? It's unbelievable how much investment has been made in producing negative information about vaccines, negative information about the virus, even negative information about drugs that don't work, or I should say positive information about drugs that don't work. The bottom line is, the virus and nocebos and placebos, there's no match. The bottom line is, you can't fight COVID with belief. You have to fight COVID with vaccinations, with masking, and with tests to make sure if you're positive, you need to isolate or quarantine. So basically, we have to kind of get our amygdalas turned down and our prefrontal cortexes in the mix. Obviously, we want to integrate everything, and so I'm not really trying to kind of bias one side of the brain or the other, but we do need to balance it out for everybody. Importantly, we realized it's not the message, it's the messenger, and we really had to partner with our community members to make sure that we got the right people giving the messages to people so that everybody can hear the message. We still have a long way to go. Over the last 2 years in Massachusetts, there have been 1.6 million cases of COVID and 23,370 deaths from COVID-19. Every death a person. Every death a mother, a father, a sister, a brother, a son, a daughter. Every death a person. Our surveillance and metrics help us keep track of the virus and the impact on the population, but we always and we always will have to look at the groups in the population, how they're affected, and there we see the striking effects of racial and ethnic disparities, the striking effect of structural racism among our Black and Latinx Americans who were disproportionately and are disproportionately hit by COVID. This disproportionate impact on Latinx and African Americans are due in large part to structural racism and the social determinants of health, the high risk of underlying disease, the high risk of chronic disease that's in our populations, residing in congregate and multi-generated settings, having public-facing jobs, reliance on public transport, limited access to care, and increased medical mistrust are an alchemy that makes for COVID severity and death from COVID. Clyde Yancey, who's the chief of cardiologists at Northwestern University, said the U.S. has needed a trigger to fully address health disparities. COVID-19 may be that bellwether event. So in summary, at the Commission, at the Boston Public Health Commission, we're committed to meeting people where they are by engaging the community, eliminating language barriers, increasing access to vaccines and testing, sharing information, providing masks and other PPE. Through our policies, initiatives, and actions, we're working together to end the pandemic. And anyone who's interested, you are welcome, welcome, welcome to join us. Thank you.
Thank you, Dr. Hall. We will not suffer for an infodemic here, thanks to all of the great information that you shared this evening, but mostly we're just deeply thankful and full of admiration for the work that you're doing out on the front lines on behalf of us all in the city of Boston. We've learned now that we are neighbors and that we hope that we see you again very soon, and we have a very small token of our gratitude here for you to bring home with you and remember us. But, oh, excuse me, that's okay. But please, if you would, just one more round of applause for Dr. Katherine. Have a wonderful evening. Thank you for joining us here at Falmouth Academy, and we hope to see you very soon. And for those at home,